Good afternoon. In the beginning, the Philippines had a centralized health system where all facilities and services, from the most basic primary facilities to the complex tertiary hospitals, were under the National Department of Health, similar to the NHS. However, in 1991, we passed a law that devolved this system. Devolution was meant to provide local governments autonomy to design and deliver services more appropriate to their local context. Primary care facilities were now under the municipal government, headed by a mayor. The district and provincial hospitals were under the provincial governor, and the regional hospitals and other specialty centers under the Secretary of Health of the national government. Because of this autonomy, local officials could prioritize strategies and direct spending to address the needs of their constituents. Unfortunately, this also led to health system fragmentation. There was no longer a single mandate from the national government for programs and allocation of resources. For example, one province can have a fully functional hospital with a complete set of health workforce, while the province next door, because of their local government's different prioritization, may not have any. Even salaries may have great variation. Without a national agency managing the system, there was no structure for ensuring integration and collaboration across the three seemingly parallel systems. Also, an unintended consequence of this was that localities with less resources were further marginalized. In addition, this new system was highly linked to politics. As the head of the health system, mayors and governors had control of interventions. Some did not consider health as a priority and had the liberty to shift financing. For those who prioritized health, the sustainability of their programs were subject to their winning of the next elections, which happens every 3 years. Also, if the mayor and the governor were not aligned politically, there was no incentive to streamline services for greater impact and efficiency. Health officers, both at the municipal and provincial levels, the equivalent of your GP with many other administrative functions, are the heads of local health offices. But because mayors and governors had control, these doctors have limited power. For instance, if a mayor does not like a municipal health officer for whatever reason, the mayor can disapprove of health programs and take away their funding. Hence, doctors who had their team of nurses, midwives, and barangay health workers, or our village or community health workers, were unable to deliver or may not effectively deliver quality care at the front lines. So now let me tell you about the health system in Northern Samar. The Northern Samar health system is dominated by the public sector. There are over 100 small barangay or village health stations, 25 rural health units, and these primary care facilities offer basic services such as tracking of patients, immunizations, prenatal care, and basic health consultations with the GP. There are also 8 district hospitals and 1 provincial hospital that provide emergency, inpatient, and outpatient care. Here, we see a map of the province of Northern Samar with its hospitals. There are 5 district hospitals, colored yellow, and they're in the islands, while 3 are in the mainland. The provincial hospital is pink at the middle and is the largest in the province, operating at 150 to 200 beds. Cases that cannot be managed in the other facilities are referred to the provincial hospital, even the 4 private hospitals you see in green. These hospitals may seem well distributed, but their service capabilities are limited. For context, only the provincial hospital has an intensive care unit or ICU and has only 4 beds. Also, there's only 1 CT scan in the province, 1 radiologist, and 1 pathologist. As for hospital-based physicians, there are a total of 52 in the province. For smaller hospitals, the same doctors performing the clinical duties are also in charge of administrative work. As you can see, the doctors are concentrated in the capital of Catarman. The health situation in the province is similar to other rural areas in the country. Maternal and infant mortality are high, and in 10 out of the 24 municipalities, more than a quarter of children are under 5 are stunted, an indicator of chronic malnutrition. As for morbidity and mortality, patterns follow national trends of the double burden of disease. Morbidity is primarily infectious and are easily preventable. Top 3 causes of death are pneumonia, hypertension, and myocardial infarction. So now, given this situation, how do people access care? Let's take a young woman, for example, who gets pregnant. Our universal hope for her is that she is able to access proper care in a health facility until she is able to deliver safely. So, when we consider health access, we think of barriers and facilitating factors that go in between the patients and the care. However, our work in Northern Samar has taught us that we need to break this down. Access to facilities is one thing, and access to services is another. Factors that hinder access include personal factors, access to transportation, physical environment, and cash. Once they get to the facilities, access to services is not always assured. This I shall explain more later. So let's discuss these factors one by one. When we had a workshop with barangay health workers or the village health workers, we asked them why they think patients did not come to the facilities. We had a cluster of answers that said, di maiwan ng ibang mga anak, or that they could not leave their other children at home. They shared how there was no one to feed their children and to care for the entire household. Another set said that they were worried because 1, the facilities were far, 2, they did not know anyone there, and 3, that they were not familiar with the place. They did not know where to go, who to talk to, and had a lack of a sense of security. They were also particularly afraid of how they would be received in the facilities, afraid to be scolded and shamed, which Dr. Joel will discuss later. Next, we asked them to map the common pathway of patients' access and various modes of transportation available for each step as they went from their home to the barangay health stations, to the rural health units, to the district hospital, and to the provincial hospital. Basic modes include walking and riding a pedicab. Although it's now very rare, some patients are still carried in hammocks or even pulled by a carabao, especially if they live in the upland areas where there are no paved roads. For land transportation, you can choose between those with 2, 3, or 4 wheels. In many mountainous areas, sometimes the only means of transportation is the habal-habal, which is an extended motorcycle that can accommodate up to 4 to 5 patients or passengers. In other parts of the country, this extension goes horizontally. Just imagine riding that coming down a mountain via a rough road when in labor or in pain. For transport across rivers and seas, we have motorized and non-motorized boats. In our workshop, one health worker served the village accessible only via 3 to 4 hour motorized boat. However, during summertime, when the water in the river is low, patients have no other alternative but to walk for up to 5 hours. As an additional note, the Philippines is ranked number 3 in the World Risk Index, a measure of a country's risk to natural disasters such as typhoons. Whether dry or wet, just imagine what you would do if you had an emergency. Now I would like to share a short video of a patient being referred from one district hospital to the provincial hospital, as an example of how an actual patient is transferred across land and sea. This patient was diagnosed with bronchial asthma and acute exacerbation.
Lunes pa magde-deliver. Tinawagan ko. Dili, oxygen. Tapos si Sir Rock. Yan, dali, dali. Kapti, misis dili. Uy. Kapti. May mutung ba? Ay, mutung ba? Dili, siguro mo na. Okay lang. Padandoy, ang sagad. Paluya mo. Wala kang kinao. Ano lang, dito na. Kabila. Okay.
So that entire transport took about over an hour. And then lastly, and perhaps most importantly, there's the factor of cash. One of the most common reasons why patients don't access healthcare is because walang pera, or that they do not have money. A patient from an island may have to pay 3 to 4 pounds for a boat ride, which sometimes is the only money they have. When they get to the facility, more cash is required of them. We encountered a patient that delivered her baby preterm and needed oxygen supplementation. One oxygen tank cost 23 British pounds, and since she did not have any more money to pay for additional tanks, the mother requested that they be discharged against medical advice and sent home. Data shows that the average cost of hospital admission in the Philippines is about 320 British pounds. Hence, a person earning a minimum wage of 3.5 pounds in Northern Samar would need more than 1 week's worth of work to afford one oxygen tank, and over 3 months' worth of income, if that was the only thing they were spending on, just to pay for a single admission. The burden of deciding between accessing health services and being pushed further into poverty is a burden that our patients and their families unjustly carry. Now, for the good news. Like many countries in the world, we are working towards universal healthcare. Just February of this year, the Philippines signed the landmark Universal Healthcare Act, which will provide changes in our governance structure as well as improve financing mechanisms. The law, for example, mandates that all government hospitals provide 90% of its beds for basic accommodations, where patients will not pay anything out of their own pockets, shifting the responsibility of care to the facilities and away from the patients. The law also promises prioritization of the geographically and disadvantaged areas, or GDAs, for augmentation of health workforce and establishment and equipping of health facilities. Northern Samar is also a recipient of the Medical Residency Rotation Strategy, where trainees of internal medicine, OBGYN, and other specialties from a regional hospital are sent to the province to augment their workforce while expanding trainees' experience and exposure to cases. Just late last year, the provincial hospital also opened their new wing, allowing expansion of services, and other smaller district hospitals are currently undergoing renovation. When I was in medical school, they taught us that one of the reasons patients arrive late in the health facility is poor health-seeking behavior. While that may be true for some, we have to recognize that there are many other factors at play in their access to care. When we understand their context better, we see that social determinants, geography, weather, and even politics all influence access. And hopefully, as we understand the barriers better, we also get better at addressing them so that one day we are assured that all patients are able to receive the right care at the right place, right time, and we can say that even in rural areas like Northern Samar, we are all together on the road towards universal healthcare. Thank you.